Hello and good morning, everyone. Today we are going to start with one more topic, which is a continuation of the common conditions of neonates. Okay, and it's a very important topic. You can say it's a high yield topic, and simply I can give it 5 stars. Okay, so to start with, what has joined us? Why it is a 5 star topics or very important topic, guys, simply because um, joined us, okay, is very common thing. Simply, uh, of course, in premature babies, they are more affected by physiological jaundice, but 60% of the term babies, 60% of term babies, uh, they they present with jaundice. Okay, so what is jaundice by definition? It is yellowish discoloration of the sclera, yellowish discoloration of the skin, yellowish discoloration of the tip of the nose, especially. So around 60% of the term babies, they have visible jaundice. Okay, there are a number of reasons like why uh, jaundice is so common, because simply um, during the fetal life, there is what you can say, they have too much RBCs in their body, and what you can say, as soon as they are born, there is breakdown of red blood cells. Okay, so this breakdown of red blood cells release a lot of you can say hemoglobin, as well as the other things. So, and also one more reason is that the red blood cell lifespan of newborn infant is around 70 days, whereas in adults that it is 120 days. So because of this shorter lifespan, the cells, they are broken down more quickly than the adult red blood cells. And the third reason you can say, um, simply, is because the babies, they have you can say comparatively premature, or like less mature liver. So that's why like the liver find it uh, difficult to metabolize all the bilirubin it is getting. Okay, so simply due to uh, you can say physiological release of hemoglobin, the red blood cells lifespan is shorter, 70 days. Okay, and the third one is that the simply hepatic bilirubin metabolism is less efficient. Okay, is less efficient, or um, because the liver is not working. uh, like one thing is called as physiological jaundice, which most of the babies get, but um, neonatal jaundice, you can say, it can be a sign of some other disorder, like for example, if hemolytic anemia is going on, if infection is going on, in case of certain metabolic diseases or liver diseases. So one thing, by the way, guys, that when the bilirubin is released, it is taken to the liver, and in like it is it is unconjugated bilirubin, which is basically the conjugated in the liver. Okay, one thing which we don't want, that there is a condition called as, of course, like when we will discuss more about the topic, we are going to discuss this thing as well, that is kernicterus. Okay, so basically unconjugated bilirubin can be deposited in uh, brain, or or basal ganglia. Okay, so which can damage these structures. We call that condition as kernicterus. So basically, whenever babies have physiological jaundice, we don't want this condition to get developed. Okay, so this is one of the thing. We treat the patients, okay, who is developing this type of jaundice, physiological jaundice, and we don't want their levels to be increased too much, so that it can lead to like kernicterus, because kernicterus will simply damage the brain. Okay, so kernicterus is simply, you can say, it is a type of encephalopathy uh, from the deposition of unconjugated bilirubin in the basal ganglia or in the brainstem nuclei. Okay, kernicterus. That condition is called as kernicterus. So simply, you can say what it is. Uh, this one, like kernicterus, is it's encephalopathy. Encephalopathy due to deposition of unconjugated bilirubin in the brain. Like at different sites. Okay, for example, like basal ganglia, or for example, different nuclei in the brain. Okay, of course, like this one can cause a lot of damage to the brain and all this one. So we don't want this condition to get developed. Okay, so simply, guys, like a breast, I think you guys know, like whenever the hemoglobins are broken down, unconjugated bilirubin is bounded to the albumin. It is taken to the liver, and where conjugation occurs, like the name of the enzyme is glucouronyl transferase, and then the conjugated bilirubin is basically excreted in the bile, which is taken to the enterohepatic circulation, and much of that is released in the form of stools called as stercobilin or stercobilinogen, and the rest is also excreted in the form of urine called as urobilinogen. Okay, so like I think we all know this thing. So what is the important things, guys? Um, like few points to remember, like before starting jaundice clinically. When the serum bilirubin level uh, is uh, between 85 to 120, basically micromole per liter. Okay, so jaundice is visible. Okay, when the serum bilirubin level reaches like to this level, it appears like it. We can see. Always look at the sclera. Look at the sclera. Look at the tip uh, of the nose, as well as, and also a very important thing to remember is always look in natural light. Okay, because if you are going to see inside the room, like in presence of what you can say artificial light, you can miss that, and once you are going to see it under the sunlight, it will be completely visible. Okay, so this thing, and the jaundice is basically, it is prolonged in certain conditions. For example, it can be prolonged with prematurity, acidosis, hypoalbuminemia. When the albumin levels are less in the blood, what happens that less bilirubin is going to bound with the bilirubin, with the albumin, so more will be in the free form. Okay, dehydration, for example, or hemolysis, all these things, they are going to give more severe jaundice. And that's why, when the babies, they have jaundice, so we check like if they are dehydrated, so we try to hydrate them. If they have like acidosis, we try to treat them, because these conditions can basically aggravate what you can say, the jaundice. Okay, so see, first of all, I would like to discuss like approach to neonatal jaundice. Okay, and nowadays, guys, because what is the important thing? Um, we always go in this way that simply we what you can say, we go on the labs, okay, when the babies are born. So we go on the labs and we check the labs first of all, just to see what is the level of bilirubin. So simply the story starts in this way, that you got a baby and the baby is born just now, you can say, sorry, not just now, like the baby. And why I'm saying this thing, again I will tell you. The most important jaundice which we have to study is called as physiological jaundice, okay, which occurs in 60% of the babies, or term babies, you can say. It never appears in the first day of life. So, whenever the jaundice appears in the first 24 hours of life, guys, remember it is never physiological jaundice. Okay, so simply we, for example, if you have a baby like 2 or 3 days old, the first thing which you will approach, how you are going to approach that, is basically you are going to check their bilirubin level, and you will think like the baby have jaundice when they have hyperbilirubin emia. Okay, so from here, the story will start, that the baby is having hyperbilirubinemia. Okay, simply, what is hyperbilirubinemia? Is the level of the bilirubin are raised in the blood. Okay, so whenever hyperbilirubinemia is there, of course, like we see either the raised level is of unconjugated uh, uh, bilirubin level, or the conjugated. Okay, of course, like we see the levels of this one. Why? Because for example, if the unconjugated is high, so we say like the baby have unconjugated hyperbilirubinemia. But if the conjugated bilirubin is high, we call it as the baby have conjugated hyperbilirubinemia, and that's how we approach, because they both have different causes, simply. So now the like first of all, of course, I'm going to discuss this one, what you can say, unconjugated one. Unconjugated hyperbilirubinemia, when it is the case, or it could be just two causes. Either it could be physiological, which is the most common, most important, okay, and most of the babies, they have this type, which is physiological, which is seen in almost 60% of the term babies. Or you can say it could be pathological. Okay, I will discuss what you can say, uh, what it means. Okay, so either it is physiologic jaundice, either it is pathologic jaundice. So of course we will discuss physiologic jaundice, and it is the normal physiologic process, because the lifespan of the RBCs is less, the liver is not mature enough, so they are the one who get the physiological jaundice. Whenever we are suspecting pathological jaundice, for example, there can be a number of reasons, due to which pathological jaundice can occur. Okay, for example, hemolysis, and in that case we call it as hemolytic type of pathological jaundice, or non-hemolytic. Okay, non-hemolytic. So this is how we approach, you can say, um, jaundice, right? So, see, um, hyperbilirubinemia can be unconjugated, can be conjugated. I am discussing unconjugated. It could be physiologic, it could be pathologic, and pathologic can be hemolytic or non-hemolytic. For example, I will give the example of non-hemolytic type of physiological jaundice. For example, the baby, when they are born, I told you sometimes there can be collection of the blood under their skin, over the skull bone. We call it as cephalohematoma. Okay, cephalohematoma. Okay, so simply like this blood have to absorb in the body, and basically it is all collection of blood. So when this blood is going to broken down, there will be increased bilirubin level, and the unconjugated one. So this one is like one of the cause of unconjugated hyperbilirubinemia. Polycythemia, for example, polycythemia. Okay, sepsis, uh, then Gilbert syndrome, and Crigler-Najjar syndrome. Okay, so these are the causes of, you can say, hemolytic, non-hemolytic type of unconjugated hyperbilirubinemia. Okay, hemolytic, on the other hand, because if we had done, when you will do what you can say anemias, you would know why hemolysis occurs. Of course, there could be, you can say, um, either there could be intrinsic problems, what you can say, there could be intrinsic problems or intrinsic problems, or there could be extrinsic issues, right? So what I mean to say by intrinsic is, like, for example, the RBC's membrane is not normal. For example, in that case, the RBC's shape is not biconcave, rather they are sphere-like, called as spherocytosis. For example, there is some enzyme deficiency, for example, glucose 6 phosphate deficiency, or pyruvate kinase deficiency, or there is abnormal hemoglobin levels, sorry, type, for example, in thalassemias. Or there could be some extrinsic causes of hemolysis, for example, immune causes. A very common example, or the best example to give for this type of extrinsic problem is ABO incompatibility or RH incompatibility. Like the baby have increased broken down of cells inside the body because of ABO incompatibility. Okay, so it could be immune problems, it could be non-immune problems, like splenomegaly, like sepsis. Okay, so sepsis can cause hemolysis, sepsis can not cause hemolysis, but can cause give for sepsis, is the cause of conjugated as well as unconjugated type of hyperbilirubinemia. Okay, so see, one thing which we can get here is simply, whenever hyperbilirubinemia is of unconjugated type, it can be physiological, it can be pathological. But guys, whenever the hyperbilirubinemia is conjugated type, so remember one thing, it is always pathological. Okay, it is never physiological, it is always pathological. Because here we cannot say this thing, because it is physiological as well as pathological, but conjugated, it is always pathological. Okay, so simply, conjugated hyperbilirubinemia is always pathological. It can have two causes: hepatic causes, okay, as well as post-hepatic causes. Okay, simply either the problem is in the liver, or either the problem is um, like after the liver. For example, what are the hepatic causes? The baby may have infections, okay, due to which there could be hepatitis going on, like hepatitis B or torch infection simply, or sepsis again. Okay, it could be metabolic causes like galactosemia, like alpha 1 antitrypsin deficiency, or like hypothyroidism. It could be due to drugs. It could be due to, if the baby is taking total parenteral nutrition, all the nutrition we are giving by what you can say, um, by the help of um, a catheter, right? Sometimes the babies, they cannot take the feed from mouth, so we give them uh, by infusion. And one of the causes, idiopathic neonatal hepatitis. Okay, so of course, like, it is idiopathic, so as you know, like, no cause is found. Whereas post-hepatic causes, guys, very easy. It could be Like, of course, like jaundice will occur if there is some blockage in the drainage of the bile, simply in the drainage of the bilirubin after conjugation. So it could be biliary atresia, okay, or it could be choledochal cyst, okay. So simply, this is how we approach. First of all, we do this test, hyperbilirubinemia. If we found, so we see either it's unconjugated type or it's conjugated type. Conjugated is always pathological. Unconjugated type can be pathological, can be physiological, right? I will change the color of that. And whenever it is pathological, it can be due to hemolysis or it can be non-hemolytic. So whenever it is hemolytic, it could be intrinsic cause or some extrinsic cause. And conjugated is simply hepatic as well as post-hepatic. So simply, as soon as you will write the test, okay, simply check, guys, what kind of bilirubin is raised. Either it's unconjugated, either it's conjugated. Always check. Either the baby is, what you can say, what is the age of the baby. Okay. For example, I told you a very important point to write over here is, jaundice in first 24 hours of life, okay, is always pathological, okay, pathological. Okay, so jaundice in first 24 hours of life is always pathological. This is very important point to remember. And as well as conjugated hyperbilirubinemia is always pathological, can never be physiological, okay. I hope you understand this point. These points are very important because, whenever, what you can say, the jaundice is appearing in the first 24 hours of life, we have to investigate that. We have to do investigations to look for all these causes, okay. Or when the jaundice is like in a conjugated type, so of course we have to see all these causes, okay. So see, unconjugated, first 24 hours of life, all investigations are needed. This one, conjugated, whenever, having investigation for all these causes, okay. So now, uh, uh, before going to the jaundice, physiological jaundice, I will say, I want to write down few more points, guys. You must have a clear idea when to investigate the patient, the patient, okay, the baby or the neonate, okay, or the infant, okay. So when to investigate the infant. So simply, guys, see, I told you in the first 24 hours of life, it is always pathological. So any jaundice presenting in first 24 hours, okay, of birth. Second thing, if you found what? Conjugated hyperbilirubinemia, okay. Always, what you can say, investigate, okay. And third thing, for example, someone have unconjugated hyperbilirubinemia, if the levels are rising rapidly, okay. I will discuss about this thing, what it is and why this thing is important. And any jaundice, you can say, any jaundice which last for 2 weeks, okay. So remember, these 4 points are very important, okay. These 4 points are basically will guide us towards, like, when to investigate the baby, okay, for jaundice simply. Okay, so if we have this one, what you can say, uh, we have these points, so we must be clear in our mind, when we have to investigate the babies. So simply, guys, whenever, what you can say, neonatal jaundice comes to us, what we do is basically, uh, we do a clinical assessment. Okay, the first thing we do is to assess the severity, okay, of the jaundice. Okay, so what they do, by the way, for example, they press the skin to assess jaundice. uh, okay, uh, like in dark skinned babies, it's hard to catch, but uh, of course, like in other colors, like it's easy to find out, what you can say, before. I'm talking about the time before, but nowadays, of course, the good thing, by the way, like before, they used to examine the skin when we don't have sophisticated gadgets, but nowadays they have something called as transcutaneous, cutaneous, what you can say, devices. Okay, transcutaneous, you can say devices or meters. Okay, to what you can say, uh, to assess the jaundice, or you can also do one more thing, or we can take a blood sample. To tell you the reality, guys, this meter, which is transcutaneous meters, uh, when I was in medical school, they were not available. But nowadays, I have seen like this thing nowadays in the hospitals. When you take your babies, or when the new baby is born, they have a meter, and they can simply put the meter on the skin of the baby, and it will tell you the level of bilirubin in their body. So nowadays, it is a very nice thing they have. But before, like when I was working in pediatrics, we used to take blood samples and we used to send it to labs for the assessment. And before these blood samples were not available, there was a time that they assess the clinicians, they assess the severity just by looking at the skin. Okay. Uh, and then, of course, like you must check, uh, either it's a term baby or preterm baby. Okay. Because preterm babies, they get more pronounced jaundice. Okay, so they have a lower threshold of treatment, if they are preterm. So then a very third thing is simply, we check the onset. Okay, if it's in the first 24 hours, of course, it is always pathological. The most common causes, think about hemolytic disease, for example. Take the blood of the baby, just check the blood group of the mother, the father, or the baby. It will give you a guide you, either it's ABO incompatibility or RH incompatibility. Okay. uh, so in the first 24 hours, we check the onset. If it's within 24 hours of birth, okay, so it could be hemolysis, right? A very important point to remember. Okay, so uh, this is very important, guys. uh, and it is like quite serious, by the way. uh, for example, if some baby have persistent jaundice, so of course, that is also serious, by the way. Okay. Always check, like, if the baby is the baby dehydrated, or there is any chances or signs of sepsis. Okay, so see, like, I think you guys are getting what I'm saying. These are the causes, and we are discussing, like, all these things, make some sense. So for example, if you found like the baby have hemolysis, what we do is, like, we check antenatal antibodies. For example, if the uh, mother blood group is blood group O, it could be ABO incompatibility. Okay. For example, if the baby is, you're working in the region, or now that this the world is global village. So if their ethnic origin is from Mediterranean region, or they are Afro-Caribbeans, they have high chances of having G6PD deficiency. Okay, so all these things matter. And one more thing, what we do is like uh, what you can say, we plot the bilirubin levels, okay, on a chart. Okay, we keep on chart, we keep on do charting, either the levels are going up or not. There is something called as normograms are available. Okay, and like we based on that we discuss like either this baby needs some uh, type of what you can say a treatment, or there is no need of any treatment, right? So like these are all the points, which you have to remember uh, about jaundice, right? So now uh, ABO incompatibility, nowadays, like it is more common than the RH incompatibility. Okay, because nowadays a lot of testing are available, and infants are usually identified before birth. Okay, and they are treated before birth if necessary. Okay, if there is RH incompatibility, and we give what you can say the mother's anti-RHD injections simply. Okay, uh, ABO incompatibility nowadays is becoming more common. Okay, and like most of the antibodies which ABO blood group will produce are like IgM, and they do not cross the placenta. But some of the women, who are blood group O, basically they produce IgG uh, immunoglobulins, right? So, or antibodies, sorry, they put IgG antibodies, so which can cross the placenta. Okay, and of course when they cross the placenta, they enter into the baby, and they can destroy uh, or hemolyze the blood. Okay, for example, if the baby is blood group A or B, of course, blood group O mother, if she's producing IgG antibodies, they can enter into the baby through placenta, and they can destroy the blood group of the baby. So of course hemolysis will occur, and it is going to produce jaundice within the first 24 hours of life. Okay, so this is very important. We do Coombs test in that case, by the way, direct antibody test. Okay, we do Coombs test, which basically detect antibodies on the surface of red blood cells. Okay, and the jaundice, it starts peaking within the 17 to 12 to 72 hours of their birth. So anyhow, like this is like you would understand when I'll be talking more about jaundice. Okay, okay, guys. The most common one is physiological jaundice. Okay, physiologic jaundice. It basically starts from 2 days to 2 weeks. Okay, like it persists for it starts within for 2 days, and it persists like for 2 weeks. Okay, so now what is physiological jaundice, guys? Um, it appears mostly around third to you can say fourth day of life. Okay, and most of the time it resolves at 10th day of life. Okay, so like this is the thing, but of course, like in prematures, it could be longer duration. It could be up to 14 days. It could be more than that. Okay, so I already told you what is the pathophysiology behind that. Okay, like this is the most common type of jaundice, right? Physiological, because, and I told you, like there will be breakdown of the RBCs, and short lifespan, and all the stuff, all the stuff. Okay, um, one thing is called as, guys, feeding feeding jaundice. Okay, and one thing is called as breast milk jaundice. Okay, breast milk jaundice, a very important thing to explain here. Now, the important thing about breastfeeding jaundice is what? Um, you know, especially in the mothers, who are the first mothers, the milk production is not much, okay, or sometimes it is not sufficient, or you can say there is lack of milk production, especially in first mothers, okay, a lack of milk production is there. So when there is lack of milk production, what happens is basically the babies, they become dehydrated, okay. They become dehydrated, and once they become dehydrated, basically the physiologic jaundice is exaggerated, okay. So the physiological jaundice is basically exaggerated, okay, because of lack of milk production. What's going on? There is dehydration, and physiological jaundice is exaggerated. So this, which is occurring due to what? Dehydration. It is the cause of, it will cause exaggeration of physiological jaundice, and we call this type or as breastfeeding jaundice, okay. If we are going to you can say treat their dehydration, the things become better, okay. So this is called as breastfeeding jaundice. Whereas what is breast milk jaundice, guys? First of all, it occurs in 1 in 200 cases, or breastfed infants, okay. And what happened, like uh, there's multi-factors which are there, what you can say, which involve, uh, in producing this kind of jaundice. But one thing, in some of the patient babies, what they found is the presence of uranyl transferase inhibitors. Okay, what they found glucuronide transferase inhibitors in breast milk. If you know, guys, see, what is the enzyme which causes conjugation? It is glucuronide transferase. Okay, so uh, in this one, what happens, like the mother milk basically have glucuronide transferase, and when they have glucuronide transferase, when the baby drink that milk, this glucuronide transferase inhibitors will go and inhibit the enzyme which is doing conjugation. So they have the presence of this kind of jaundice, okay. Onset is around 7 days of life. It peaks in 2 to 3 weeks of life, and it usually resolves by 6 weeks of life. Okay, so and previously, by the way, what happens is you can say the doctors, when they found, or when they suspect that the baby may have breast milk jaundice, what they ask the mothers to stop feeding. But nowadays it is not recommended, but the recommendation is simply to continue feeding, okay. So nowadays the doctors, they don't allow, or they don't say uh, you can say to stop feeding these babies, but they keep on saying to feed them. And what happens, what you can say, they overcome this condition, okay, by 6 weeks of life. So dehydration, see, is one of the cause which will exaggerate. Infections, for example, when the babies, they have infection, they may develop unconjugated hyperbilirubinemia. Why? Because in infection they have poor fluid intake. It can lead to hemolysis. It can lead to reduced hepatic function. It can increase enterohepatic circulation. So Of course, if we are suspecting any infection, we have to treat that. Okay, so risk factors, guys. Risk factors. If we will talk about the risk factors of physiological jaundice, there are many risk factors. Okay, risk factors which can lead to um, physiological jaundice. So there is a lot of risk factors. For example, maternal risk factors are there. Then perinatal factors are there. Okay, as well as neonatal factors are there, or you can say the neonate factors. So what are the maternal risk factors which can lead to jaundice? Asians, okay, they have more physiological jaundice. Um, for example, diabetic mother, they have more breastfeeding. I already explained why it can lead to dehydration. If someone have family history of physiological jaundice or XYZ, any complications during pregnancy, right? Neonatal risk factors, perinatal risk factors, any baby who have birth trauma, of course, it can lead to cephalohematoma or prematurity. Okay, so whenever these risk factors are there, of course, they have increased chance of physiological jaundice. Infections, polycythemia, as well as drugs and total parenteral nutrition. These all risk factors can cause, you can say, physiological jaundice, right? Okay. So, guys, now you know the important thing. Uh, Remember, I told you, whenever jaundice occurs in the first 24 hours of life, it is always pathological. Whenever jaundice is conjugated, it is always pathological. Now, to tell you, uh, for example, if someone have jaundice in the first 24 hours of life, think about hemolytic disease, think about Rh incompatibility, think about ABO incompatibility, think about sepsis, think about congenital infections like torch infections, and think about uh, hemorrhage, for example. Whenever the jaundice starts after 24 hours of life, or not in the first day of life, 2, 3, or 4 days of life, think about physiological jaundice, think about dehydration or breastfeeding jaundice. Uh, Again, you can think of hemolysis, polycythemia, G6PD deficiency, pyruvate kinase deficiency, bruising or hemorrhage, of course, or sepsis, right? But whenever the jaundice is occurring after 1 week of life, you have to think different conditions, okay? So what I'm saying here, uh, for example, causes of jaundice by age, okay? Less than 24 hours, what you must think of? Hemolytic, okay? As well as it could be sepsis, it could be torch infections, okay? It could be what you can say hemorrhage, okay? Hemorrhage or bruising, whatever. Whenever jaundice is like from 24 hours until you can say 96 hours, okay? Think about physiological jaundice, think about dehydration, think about polycythemia, okay? Think about hemolysis, think about enzyme deficiency like G6PD or pyruvate kinase deficiency. Think about again hemorrhage, okay, and sepsis. Okay, but whenever like it is, if it starts for after more than 1 week of life, okay, think about now the conditions will completely change. Breast milk jaundice, okay. Think about if it's a preterm, you can think about physiological jaundice because it lasts for more than 1 week, rather sometimes more than 2 weeks. Hypothyroidism is one of the cause of jaundice. Neonatal hepatitis can be the cause, as well as think about syndromes like Gilbert syndrome uh, and Crigler-Najjar syndrome, for example. Crigler-Najjar syndrome, for example, or inborn error of metabolism. Okay, so and think about biliary atresia or choledochal cyst, right? Now, see, the important thing, guys, here to make some concept is uh, like this is how we approach the patients, right, of jaundice, and I will tell you now. Okay, this Gilbert syndrome is coming again and again. Okay, so uh, to tell you, Gilbert syndrome is basically a condition in which what you can say, uh, like the you can say um, the liver is not processing the bilirubin normally. Okay, and these are the people like who what you can say who have simply you can say decreased levels of the enzyme glucouronyl transferase. Okay, so Gilbert syndrome people, they have decreased level of what glucouronyl transferase, which is doing the conjugation, which is basically uh, mm, converting the unconjugated bilirubin to conjugated one. So of course the enzyme involved is called as glucouronyl transferase. So these patients, they have decreased level of glucouronyl transferase, and this is because of mutation in one of their gene. Okay, but you don't have to go in too much details because that's not important. Okay, if you know this thing, like they have decreased level of glucouronyl transferase, I think that's enough right now. So like most of these people may, like, maybe they are around you and you don't know. Even they don't know they have this kind of syndrome because they stay fine, they stay normal, but simply whenever they have some stress, like they undergo some extreme, you can say, exercise, or they do starvation, for example. So what happens is, like, the level of their bilirubin increase for a while and they appear jaundiced. Okay, so like this is Gilbert uh, syndrome. Okay, now like rest, like they are completely normal, by the way, guys. Okay, so there is like two syndromes basically, you can say, which gives conjugated hyperbilirubinemia, and there are two cases which gives unconjugated type of hyperbilirubinemia. Okay, so simply we call them as, there are four syndromes. One is called as Dublin syndrome, one is called as Rotor Johnson syndrome, one is called as Gilbert syndrome, and one is called as Crigler-Najjar syndrome. Okay, so uh, the one which is here, Crigler-Najjar syndrome, for example. Okay, so they have what you can say more severe deficiency of the same enzyme glucouronyl transferase. Okay, and simply because they have like more severe deficiency of this enzyme glucouronyl transferase, so they have increased unconjugated level of bilirubin in their blood, which can basically deposit it in their brain and they can cause brain damage. Okay, so you can say Crigler-Najjar syndrome people, they are usually normal because they have mild deficiency of glucouronyl transferase, whereas when the deficiency is too much increased, Crigler-Najjar syndrome is one of the cause, right, which can cause so this one, Gilbert syndrome and Crigler-Najjar syndrome, give what kind of jaundice? Unconjugated hyperbilirubinemia they can cause. And two syndromes which I told you, one is called as Dublin-Johnson syndrome and one is called as Rotor syndrome. They give what you can say uh, conjugated hyperbilirubinemia. Dublin-Johnson syndrome, it's very rare. Okay, and in that one, what you can say, there is increased level of conjugated bilirubin in the blood. Okay, so simply what happens in this one is basically uh, the bilirubin after conjugation, they cannot leave the liver cells, you can say, okay, or simply there is a defect in the hepatocytes, to to excrete the conjugated. See, unconjugated bilirubin is going into the liver, and now after conjugation, uh, the liver cells must transport that conjugated bilirubin into the bile duct. So simply this that things like that thing is not working properly, and that's why when we see the liver of these patients, like of course like when they do biopsy, because there is entrapment of all the conjugated bilirubin inside the liver cells, their liver appear black in color. Okay, so simply again, it's a autosomal recessive type of condition, okay, which is present in a lot of people. So now, like this is one of the thing, and rotor syndrome is another syndrome which gives conjugated type of hyperbilirubinemia. Okay, it is also a rare condition. Okay, and but again it gives conjugated hyperbilirubinemia. Okay, uh, and the main difference between what you can say between Dublin and Rotor-Johnson syndrome is what that in Dublin-Johnson syndrome, liver is dark or black in color, whereas in Rotor syndrome, when we see the liver, it is normal uh, tissue. Okay, like there's no big difference. So this thing again, like it's autosomal recessive condition, and again there is absence of some genes which causes this kind of condition. Okay, so anyhow, like this is like I was just talking about what you must think of the conditions, if it is within 24 hours, or from 24 hours to 96 hours, or after 1 week of the life. Okay, to talk about the pathological jaundice, guys, uh, like pathological jaundice. Okay, so pathological jaundice are simply it could be due to hemolysis, it could be due to what you can say absence of the biliary tree, or it could be due to cyst, it could be due to sepsis, it could be due to like all the things, just remove this part, all the rest are pathological jaundice, right? So uh, like when we'll discuss pathological jaundice, of course we must discuss like how we can proceed with investigations in someone who have pathological jaundice. For example, one of the conditions is called as biliary atresia. Okay, now what is biliary atresia? As you know, see, atresia is there and biliary tree. So simply there is absence or like malformation of the extrahepatic bile ducts. Okay, so it is basically atresia of extrahepatic bile ducts. Okay, so when there is no bile ducts, what will happen? The bile cannot be transported, which will lead to cholestasis. Okay, which will lead to cholestasis. Okay, and when there will be cholestasis, what will happen? The bile cannot be transported into the biliary tree because there is no biliary tree. So there will be increased in what kind of bilirubin? Conjugated or unconjugated? Now see, the liver is normal, the liver is doing conjugation, but that conjugated bilirubin cannot be transported to the bile duct, so simply there will be increased conjugated bilirubin. Okay, there will be increased conjugated bilirubin, of course, after the first week of life. So, biliary atresia is one of the cause of what you can say, you can see over here, post-hepatic jaundice, right? So, now, guys, the important thing about this condition is what? See, the biliary tree is not there. And if we are not going to treat it, what will happen? That simply the bile will be collected inside the bile ducts, okay? And of course, what you can say, all the bile ducts can be blocked simply, and it will lead to progressive damage to the liver. Okay, makes sense. Like, of course, like the bile duct are blocked, so not there, so simply like the bilirubin will keep on collecting in the liver. That's what is also called as progressive obliterative cholangiopathy. Okay, so this one is also called as you can say progressive obstructive cholangiopathy, because due to progressive, what you can say, damage to the liver, like, of course, it is going to cause this thing. Not so common, but like 1 in 10,000 or 1 in 20,000 live births, this kind of condition occurs. And there is association with a lot of other anomalies, for example, situs inversus, in which, practically speaking, uh, all the structures of the body which are should be on the right side are on the left side. Okay, there is a condition called as dextrocardia, in which the heart is on the right side, but sometimes the liver, which is on the right side, is on the left side. So that is called as situs inversus. All the structures which are on the right side, they are basically on the left side. Okay, so like many people who have situs inversus, they have this condition. Sometimes there is uh, congenital heart defects which can produce, which can occur in this one. So guys, see, now biliary tree is not there. So basically, all the bile which is formed, they are not transported into the intestines. So all of that will be absorbed in the blood, which will result into dark urine, the blood, but nothing will appear in the stools. So there will be pale stools. Okay, and of course they will present with jaundice. Okay, and this jaundice will persist for more than 2 weeks, and they will present with abdominal distension. Okay, they will present with abdominal distension as well as hepatomegaly. Why? Think logically, because the liver, more and more, what you can say, bilirubin is stored inside, not stored, rather is collecting inside, what you can say, the inside the liver, so which will lead to simply, you can say, hepatomegaly. Okay, so now, what is the condition? The biliary tree is not there. So of course we do the test. We found what kind of thing you will found is like conjugated hyperbilirubinemia. Okay, makes sense, right? We can do abdominal ultrasonography, and we can do cholangiogram. Cholangiogram. What is cholangiogram? Like, they give a dye and they see the biliary tree, and of course, like, that is not present in this one. One of the investigations is called as a HIDA scan. Okay, HIDA scanning is used, guys, for what you can say, for visualizing the what you can say, the biliary tree, and we can also do liver biopsy. Okay, so all these things we can do in this one. And now, of course, see, the biliary tree is not there, so that is something, which cannot be reconstructed. So the important thing, like, if we are not going to provide them with urgent treatment, which is liver transplantation, they can die. Okay, so of course, surgical drainage procedure can be done for some time. A treatment called as hepatoportoenterostomy. Okay, just to drain all the things over there. It is also called as a Kasai procedure. Okay, should be done within 8 weeks of age. So ultimate treatment, most of the patients, basically, they need liver transplantation. That's it, because all these procedures, they are not so good. So most of the patients, they need ultimate treatment, liver transplantation, of course. And before liver transplantation, of course, because they don't have bile coming from the liver, they cannot absorb all the fat soluble vitamins. We have to provide them with vitamin A, D, E, and K. All these are what? fat soluble vitamins. We have to give them these vitamins, provide them with these vitamins. We have to give enough amount of fats, especially medium chain triglycerides, so that their growth will be normal. And of course, then we in that time we prepare the things for liver transplantation. So I think we are going to finish this lecture over here, and in the next lecture we will talk about how to investigate the patients. Okay, like we'll talk about all the investigations, then I will tell you what is kernicterus and how we treat physiological jaundice. Okay, thank you so much.